Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everybody, and welcome to episode number 37 of the Better Health Guy blogcast series. Today's guest is Dr. Keith Berndtson, and the topic of the show is SIRS Update. Dr. Berndtson is a graduate of Rush Medical College. He practiced in Chicago for over 28 years and has clinical and administrative experience in both conventional and alternative medical settings. He served as a clinical instructor for students at local medical and health professional schools. He is the author of Seek Wisdom, The Modern Quest for Health and Sustainability, a collection of essays on healthcare and what's needed for us to become wiser stewards of nature. He co-authored The Immune Advantage and has been a consulting editor for several health publications, including the Reader's Digest Guide to Vitamins, Minerals, and Herbs. He is certified by the American Board of Integrative and Holistic Medicine and specializes in the evaluation and management of symptoms that persist despite usual medical care. He's undergone additional training to help his patients address Lyme disease and other tick-borne infections. He is the author of a widely read, peer-reviewed article, Review of Evidence for Immune Evasion and Persistent Infection in Lyme Disease. He is certified by Dr. Ritchie Shoemaker to help genetically susceptible patients address the chronic inflammatory response syndrome caused by mold toxins found in water-damaged buildings. And now, my interview with Dr. Keith Berndtson. So I have followed Dr. Berndtson's work for several years now and have connected with him both at Shoemaker conferences and ILADS conferences. And I'm drawn to the fact that he really considers both mold and Lyme in the work that he does to improve his patients' health. So I'm honored to have him onto the show today. And thank you very much for being here, Dr. Berndtson.
It's a pleasure to be here with you and your listeners.
Thank you. So what drew you to the world of SIRS, or chronic inflammatory response syndrome, and more specifically to mold illness and Lyme disease? Was there some kind of personal connection that you had to either of these challenging conditions?
Well, I have to be honest and say that I wasn't drawn so much into Lyme, which came first. I was pushed into it by patients who said, "How come you're not, treating Lyme?" And I said, "Well, I don't know enough about it." And they would respond, "Well, we need you to know more about it." So when the Tick-Borne Disease Alliance decided to fund a week shadowing Dan Cameron back in 2013, he was president of ILADS. That was a great experience, and it really boosted my confidence and, the sense that I could get into this. But before I started opening the door to these patients, I worked on a review of evidence for immune evasion and persistence in Lyme disease for two reasons. One is I wanted to learn more, obviously. The second was if I was the only physician in Illinois who was taking these patients on, maybe a published review would function as a shield, so to speak. It turned out I didn't really need a shield. Never got any flack for treating Lyme a little bit differently. And the paper did well. It was downloaded over 5,000 times and I think viewed over 59,000 times. I've enjoyed it a lot. And early on, I was consoling myself in treating the Lyme patients by saying, well, at least I don't have their problems. Well, so the karma came back at me. Because 2001, I got very sick with a flu-like malaise, fever, chills, sweats, on the way back from a canoe camping trip in northwest Wisconsin. And one thing led to another. I got diagnosed with sarcoidosis. That was after the radiologist showed me my chest CT and said I had Hodgkin's lymphoma. Well, that was wrong. But so was sarcoidosis. I found out 11 years later in 2012 when, I do one of the things that I love to do the most, and that's troll PubMed for interesting stuff. Came across 2 case studies. Between the 2 case studies, they had 4 or 5 of the things that I had in 2001. I had erythema nodosum, involves the lower legs. I had uveitis and inflammation of the eye tissues. I had a big spleen. I had a big liver. And I had a mediastinal node biopsy that was positive for granulomas. And even today, if you show with those things, they'd probably say, all right, this is Lofgren syndrome, you got sarcoidosis. Well, these 2 patients in PubMed both had Bartonellosis. Now it started to make sense.
Yeah.
So had my blood sent to Galaxy and it was positive. And wound up getting treated for Bartonellosis and getting a close-up and personal idea what Herxing's all about.
Right.
So then I have to give Lisa Petterson, Lisa.
Mm-hmm.
She came into my office in 2007 with Mold Warriors, one of Ritchie's books. And, I kind of thumbed through it and came to a snap judgment that there wasn't much to learn in it. Probably let it sit for a year or more, and had a long weekend and decided to get into it. And I kind of got interested in or drawn to his talents as an essayist. He's got some really nice essays, and you can't just view it as a textbook. You have to dig back and forth to kind of figure out the CIRS markers that he's uncovered and what they mean in that book. But you pan back and you get the really broad view of how this affects families and how schools get involved and legal tussles ensue. And, it made it very clear that this is unlike, any medical condition that I've ever had to deal with in, 30 years of practice. So at that point, I decided I'm probably seeing these patients and not recognizing what's going on. So there was a certification process and, up and running at that time. And, it's an open book exam. I took it, passed it, became one of the first few doctors to get certified.
I think you make it sound a little easier than it probably actually is, because I know you have to do essays and all kinds of other stuff. So I suspect there was a lot of work involved in that certification.
I will say this: it's sufficiently challenging. It's you could view it as an idiosyncratic kind of certification process, but there's no board, for this.
Right.
It's got to start somewhere, and it's pretty hard to wrap your head around. All the stuff that Ritchie has uncovered in 20 years of keeping data. And it's not a slow-moving field either. I mean, we'll talk about this in coming minutes, that there's lots of interesting new things that are happening that makes it pretty clear that as much as we hate maintenance of certification and having to get certified over and over again, there may be an argument for that.
So for those people listening, you mentioned Lisa Petterson. She has a website or blog that's really fantastic for people dealing with mold-related issues. That's Paradigm Change. So if you just Google Paradigm Change and mold illness, you'll find her site, and that's certainly worth exploring. We've heard Dr. Shoemaker talk a lot about the visual contrast sensitivity test and how that's used as kind of an initial screening test for biotoxin illnesses. And we know that when people historically fail that test, it takes a lot of work to get people to the point that they actually pass it, either removal from exposure, cholestyramine. It's not usually a very quick thing. And so I understand that recently you've seen some type of air cleaning device that can cause that going from a failed VCS test to a pass test to be something that happens much more rapidly. Wondering if you can share that with us.
Yeah, so Vince Neal is the principal of Mycotox. It's a indoor environmental professional firm in Newcastle, Australia. And he's worked with the Air Oasis company to develop a really highly powered air cleaning machine. He demonstrated it for me when I arrived in Australia for the conference last month. There was one in my room.
Nice.
He was already cleaning the air in the room, and he had an even bigger one that he had in the conference area. But what he's shown and has replicated a few times, and of course, we want to see independent researchers replicate this kind of stuff, is that in a home where a patient, with SIRS was exposed, she would do the VCS test and fail it, and then he'd turn on the machine and, give it a few minutes, and she would repeat the test and pass it. So what's going on? Well, let's take a step back and try to describe how VCS became of interest to us in the first place. It's long been known that systemic inflammation and or toxicity syndromes can produce, and many patients have heard this phrase, capillary hypoperfusion. In systemic inflammation, especially in SIRS, what's happening in inflammation zones is that signals are going out to recruit more white blood cells to the inflammation zone. And usually that works because the white blood cells show up and they take care of business. They get at the source of the inflammation and, clear things up. Due to the genetic susceptibility, which we still don't fully understand, that's not getting done. And so the white blood cells keep getting recruited. And so now you're getting a traffic jam of cells and proteins in this area. And it's hard for the red blood cells to squeak through and deliver the oxygen and nutrition that is their job, and pick up the trash on the way out. So the Department of Defense was interested in quick ways to determine who's toxic or who's inflamed. And they knew that anatomically, if you look at the optic nerves where they arise out of the back of the eyeballs, the upper outer portions of them have a weaker arterial feeder supply than the rest of the nerve. So they thought, all right, well, if we can figure out what the fibers, what the neurons in that part of the fiber optic cables on both sides, what information they're carrying, then maybe we could test that as a gauge to who's inflamed and who isn't. And lo and behold, that's how it worked out. So, so now back to Vince Neal and the Strong Air Oasis unit. It certainly suggests that if we can clean the air enough, such that there's either a decrease in inhaled inflammagens and toxins, or possibly decreased danger signals coming from olfactory nerve receptors carried by neurons passing along danger signals. The olfactory nerve projects to a dozen or so other areas in the brain, and this is how people can get such immediate reactions. Just a little sidebar, when patients with multiple chemical sensitivity first came to my attention many years ago, I told myself, this can't be happening. There's no way to explain this.
Right.
Well, now there is. And even in Alzheimer's research for a while, changes in olfactory sensitivity was being used as a potential screen for cognitive decline and early Alzheimer's. So the phrase that we use is olfactory insults, where VOCs, toxins, inflammagens, they're all stressing out these olfactory receptors. The nerves are sending signals that might actually be playing a role in neuroexcitability and some of the manifestations in the form of anxiety and irritability and just feeling scatterbrained. So in any rate, if you clean the air enough indoors where there is exposure, but you can reduce the exposure to the olfactory nerve or inhalation, that maybe that's enough to improve capillary perfusion. And it's interesting. I tend more to the olfactory hypothesis, but it is speculation. I say that because the optic nerve is a cranial nerve and the olfactory nerve is a cranial nerve, and it might be able to change things that fast. We don't know for sure, but it's an exciting finding because when you're certified to treat CIRS patients, one of the first obstacles you run into are the patients who are stuck at step one.
Right. Yeah.
And we're thinking, well, what do we do? I mean, time's going by, and we learned that cleaning the air, there are several different types of units that can get the job done, will at least make things more bearable for the patients. That become somewhat less systematic. We don't usually get them to a point where we can green light the treatment and expect good results until they're fully removed.
Right.
What's analogous to Vince's, powerful air oasis machine is the fresh air effect that people have when they, go to the mountains or the coasts or whatever. And they sometimes report that they feel normal again. And then you go back to your moldy loft and you're flattened.
It's interesting because I always say that the Shoemaker protocol, which I believe is about 11 steps, that once you get past step one, you're well over 50% of the way, because that really is the hardest. So the question people will have based on your comments here is, how is that Air Oasis machine different from the other Air Oasis devices? Meaning, can they purchase this unit commercially, or is it the 3,000? Is it something different than what's currently available?
It's not commercially available yet. It's being test marketed in Australia, and I think it will be available at some point. But it just boils down to the rate at which how many cubic feet of air get cleaned.
Mm-hmm. Awesome. Cool.
It's much higher than any of the stuff that's available here so far.
That's great. Yeah, I've always got 4 or 5 air filtration devices in my home, trying to keep it as clean as possible. So let's talk a little bit about transcriptomics. So we've heard Dr. Shoemaker talk about transcriptomics, or how genes are transcribed or how they're expressed. And then more recently, his work around being able to identify a fingerprint around kind of those underlying issues that lead to CIRS. And so what I'm wondering is if you can talk to us about how this is done, what types of genes are evaluated, and what are the triggers that lead to specific fingerprints of gene expression?
Well, great questions. It starts with what we call next-gen sequencing. And it's looking at the way genes are expressed before and after, doing some kind of intervention. That's the model that we've been using the most. And though we say genomics, more technically it's transcriptomics, which means we're measuring RNA as opposed to DNA. But it gives us a very clear idea of what's changing at a genetic level. So the company ProGene-Dx, and that's Ginny Ryan is the chief science officer there, and Ritchie's part of the team, and they're doing some really fantastic work to the point where we might even find that they can read the genomics results on someone and tell whether they got CIRS or not, and the results might conflict with what we're diagnosing using the old proteomics, the MSH and the ADH and the TGF-beta and the VEGF and the NFP9 and the C4A and so on. So it's a rapidly changing field, and it's going to be very important to make sure that certified doctors and practitioners are being kept up to date, on what to do when things are not matching up. We found out early on that if you measure the genomic or the transcriptomics before VIP and after VIP, that what you'll see is the VIP2 receptors are increasing in quantity, which is what you'd expect to happen. All of a sudden, there's more VIP. The body's responding to that, so that more of that message can get through. The VIP2 receptor is responsible for the dozen or so anti-inflammatory effects that VIP has. It has 12 distinct ways of trying to dial down inflammation. The other thing that it's known for is being a master regulator of the microcirculation. We talked about the traffic jams in the microcirculation. Well, VIP's job is to try to normalize that so that the red blood cells can come through on their value proposition and deliver the goods. So we see a lot of improvements on VIP. There are some, side effects that can occur. We're not sure exactly what causes it. Maybe it's reperfusion stress, where all of a sudden more oxygen is being delivered than the cells and tissues were ready for, and you might have some oxidative stress. So we see some fatigues and headaches, changes in mood, and so forth. But for the most part, that patients see that subside and they can tolerate and move on. There might be a few patients who just can't keep doing it because it's.
So most people, when they think about genes, we're thinking more about SNPs, the things you get from something like 23andMe. And the way that I understand it is that's your potential, but it doesn't necessarily always mean that a gene is expressed. And with the testing that you guys are doing now with the transcriptomics, what we're actually looking at is whether or not a certain gene is expressed or whether it's in its stressed state. Is that a reasonable understanding of the difference between the two?
Yeah, you nailed it. The SNPs are telling you what your risks are. We can only guess at whether something's being expressed or not based on what demand there might be for increased methylation or something in the system. But what the genomics does is tell you what's being activated and what isn't.
And with the tests that you've done thus far, what types of fingerprints or patterns have emerged? Is there a mold pattern, a MARCoNS pattern, a Lyme pattern? What kinds of things can you deduce from looking at the stressed genes that are being expressed?
Well, for the most part, we've been focused on the CIRS. I know that Ritchie's working on some Lyme genomics assays to see if we can sort out, who's got what. But we're not quite as far on that as we are on the CIRS. The biggest finding so far has been that ribosomal genes, and I'll explain this, are downregulated in the CIRS afflicted. Ribosomes are the protein synthesis factories that are present in the cells of every living thing. And we're not sure why they're down, but we now have reasons to suspect that ribotoxins might be the cause of this. Now, get ready, folks, because we're going to dive into the deep end of the pool. Ribosomes have two main subunits, a smaller one and a larger one. In human cells, the larger subunit carries what's called a sarcin, S-A-R-C-I-N, hyphen ricin, R-I-C-I-N, loop. So we call it SRL, sarcin ricin loop. Well, ribotoxins will bind to that loop on the ribosome, and when they do, it grinds protein synthesis to a halt. That cell, that ribosome, I should say, is not going to be making protein. Now, that's not happening in every cell of the system. It's here and there, wherever the ribotoxins may find their way into a cell. it's not going to take long if there's enough of that going on, that you're going to start to feel weak, because the proteins are not getting made. All right, so that's a really important finding. And ricin, I think if we went back to maybe the 1980s in Japan, there was some crazy loon who released ricin in a subway or a bus or something, and it was legal for some of those people to get a high enough dose. But Aspergillus can make sarsen, which is another ribotoxin. Actinomycetes, also known as actinobacteria, which are filamentous bacteria. They remain viable pretty easily. I mean, they can live on concrete. And what filamentous means is it's just sending thread-like projections, in various directions, and it increases the surface area, and so what we call biosurface antigens are produced in greater abundance by actinomycetes than, common molds. And, they make aflatoxin. All right. At least some of them have the genes that code for, technical term is secondary metabolites, molecules that they don't keep inside their cells, but that they release into their environments to give them some kind of advantage. All right. So that's a link. And, there's a microbiologist, again from Australia, but he and a colleague are setting up, I think they're going to call it Mold Lab in Texas. Maybe it'll have a different name in San Antonio. But they'll be doing bacterial DNA analysis, just like Mycometrics is doing mold DNA analysis. And, there are so many actinobacteria that the big challenge initially for them is to try to sort out which of the hundreds do they want to look for. And they've kind of narrowed that down. And many of us are predicting that may be the biggest troublemaker in water damaged buildings.
Well, and that's a thing that we should bring out here. So beyond just the mold, there's 30 or so other compounds in water damaged buildings, and the actinomyces that you're talking about here, the bacteria that potentially also is releasing toxins, is one of those things, as I understand. Right. And so besides just the mold and the mycotoxins, we've got the VOCs, we've got bacteria like you just talked about. I was actually surprised to see that chlamydia, pneumoniae, and mycoplasma are also ones that are elevated in these water damaged buildings. And I think those are two bacteria that people often are dealing with chronically as well. And maybe it's in part because of constant re-exposure to them.
No, that's an excellent point. Mycoplasma and chlamydia, they're a class of bacteria that are not much bigger than viruses. And so they're probably biofilm participants. I think that work has shown that they are. There's many opportunities for biofilm to form in water damaged buildings on surfaces. And so, it's possible that water damaged buildings are a source of exposure for mycoplasma and chlamydia. And if they get into a system that's compromised from an immune standpoint, then now we've added another stealth infection or two to the already complicated equation.
So you mentioned the ribotoxins. Is cholestyramine also a binder of those toxins that are ribotoxins?
That's an excellent question too. I'd have to look up the anionic charge or the ionic charge information on those toxins. But in general, most of them are negatively charged, which means, a positively charged binding agent like cholestyramine or Welchol should work pretty well.
So with the transcriptomics testing, we can see a change in the before and after VIP therapy in terms of which genes are in a stressed state. Are there any other compounds that have been studied thus far, maybe supplements, herbs, other things that may also help to get the genes to shift out of that stressed expression?
You are so full of good questions. I have to backtrack for a second because we just want to finish the story on the
Sure.
SIRS loop. Before and after VIP corrected the problem, which is stunning to me because, VIP is not binding and removing things from the system, but it may be doing things that allow the immune system to, process the toxins properly so that they're not toxic anymore. And it was stunning, and it correlated with improvements in symptoms. So I really think the ProGene boys are onto something with
Awesome.
that finding. That would have application to virtually any chronic fatiguing illness, where fatigue and weakness and poor stamina are significant parts of the mix. It's opening new doors of investigation, and we can have some real aha moments in the next few years from it. In terms of other genetic findings, one of the other earlier ones was upregulation of the expression of what we call alpha defensins. Actually, I can't remember exactly if it was alpha defensins or beta defensins, but these are released as first-line defenders. We've got cells in the bowel. They're called Paneth cells that release these defenses, and they're trying to basically attach to and break down microbes that are posing threats. So we know those defenses are getting activated, and when it came to our attention that defenses in the bowel might be involved as well, then that's one of the things that got us to really think seriously about whether dysbiosis and leaky gut, with those broken tight junctions and the portals of entry that exist, whether that might be another source of SIRS inflammation triggers and toxins. So you might have patients who've removed themselves from exposure and they continue to run high TGF-betas and have symptoms, and you do the review of systems, and the mere act of eating makes them feel sicker. There might be an acute GI disturbance or a delayed headache or a sense of fatigue. They might have limited themselves down to crazy low number of foods. I think we have to seriously think about whether that's another source of SIRS inflammation that needs our attention. And it's speculative. We don't really have data to show. It's hard to even think of a research design that would help us show that is part of SIRS. But that's one of the things we're interested in looking into. I guess while I'm on that subject, it's interesting that there's a lot of TGF-beta in the system. There's some of it operates in the bloodstream, some of it operates in the tissues. When we measure C4A, that's active primarily in the bloodstream. And so one of the other signals that kind of gets me worried about a leaky gut as a problem in SIRS is a TGF-beta that's really high, and a C4A that looks normal or low normal. And we have to concede that when you draw a tube to measure TGF-beta, you have to spin it down twice. You do the first spin down to get the serum, and then you have to do a second spin down get the platelets out, because platelets can release TGF-beta, and if you leave them in too long, they're going to empty their TGF-beta, and it's going to look artificially elevated. But when it's done right, if the TGF-beta is high and the C4 rate is low and the gut seems to be a problem, then it might be possible to treat the leaky gut. I'll share that what seems to be vaulting to frontline therapy for that is the lignite in liquid form.
Mm-hmm. And is that Zach Bush's Restore for Gut Health?
Yeah. Those plant-based molecules from soil have such large range and variety. They seem to form something like a sleeve that creates a barrier in the bowel space, and that can do its part to help shift the gut wall out of damage control mode into restoration mode, and maybe repair some tight junctions. The second thing that might work synergistically with that would be IgG from bovine sources, either bovine colostrum or bovine serum, where the IgGs are intercepting antigens, and it's more like a biological binding system. Once they're intercepted, they're going to be carried out with bowel movements.
So is that more like some of the products from the IgG products from Zymogen, or is that more like the Sovereign Labs colostrum types products? What are you referencing there?
Well, yeah, Zymogen and Orthomolecular are offering IgG concentrates from colostrum.
Okay.
The colostrum contains some growth factors. Maybe that's helpful as well. Interrogam is IgG concentrates from bovine serum, and any one of those could prove useful. But the question is, in somebody who's not exposed, we'd also like to show that they don't really have strong evidence for stealth infections. That's a challenge. Who has ongoing SIRS inflammation and symptoms and bowel problems, and we treat the leaky gut, and what happens? Do their SIRS markers settle down? Do their symptoms come down? If so, we're starting to get closer to the idea that this is an area that needs to be attended to in some SIRS patients.
So with the gut piece, it sounds like leaky gut potentially is, and likely is, at least a contributor to systemic inflammation in people, whether or not they have SIRS, if they get those reactivity to foods that are crossing through the gut membrane. What about the microbiome? Is there anything that suggests it may be helpful to do certain types of probiotics or other things in a SIRS patient?
Well, this is a great question. It came out at the Australia conference, which was focused on the human gut microbiome. And, there's so many different probiotics to choose from out there that there are only a couple handfuls of probiotics that have really been tested and their mechanisms of action documented and so forth. There were a couple of gut microbiome experts, one from California, one from Canada, and they definitely recommended that you go with the ones whose mechanisms of action we understand. Instead of just going for the most billions or even the most diverse. We know that if you've got low diversity in the microbiome, you're at risk. You're at risk of potential pathogens or bad actors rising up to dominate that ecosystem and create trouble as SIBO or in other ways. But if you've got an actively leaky gut and we start introducing highly diverse strains, which is the goal, it could be that some of the surface markers from those probiotics will be inciting some inflammation.
That makes sense. Yeah. Or there specific, I know there's a lot of talk recently about the Megaspore biotic from Kiran Krishnan. Are there specific ones that fall into that category of having a well-defined mechanism that we understand that you think are good to explore?
Yes. All right. So Megaspore, those bacilli, what they can do, very well documented. Fluorostor or, Saccharomyces boulardii, same thing. They're transient. They're not taking up a long-term residence. They hang out for 2 or 3 weeks, but while they're there, they're policing the system and providing the intestinal cells, some of the things that they need to deal with the stress that they're under. Those are helping, in the early phases. Once we settle the gut down and we think we've got, a functional integrity back with the gut barrier, you can start trying to increase the diversity of strains. And that's how you might, restore a normal bowel and it's no longer a chronic inflammatory variable in the equation.
Or there are a couple of comments maybe that you have about specific dietary recommendations that have been helpful for people with SIRS.
Yeah, I mean, the easy recommendations are, if it tastes good, spit it out and you'll be fine. I have to remove sharp objects if I'm trying to tell somebody to avoid gluten if they're from Italy or Ireland or pre-adolescence or adolescence. But no, I mean, we can check a celiac genotype to see if you've got one that's permissive. You could have a celiac permissive genotype and eat gluten every day and never have a problem unless and until you develop a leaky enough gut for that switch to get flipped on. What we have to factor in is that even if you don't have a celiac permissive genotype, you can have some significant, inflammatory activity going on from non-celiac gluten sensitivity, which first, came onto the scene in 2005, and Fasano and colleagues have been, busy studying that. First, we thought maybe it's causing malabsorption and that's it, but now we can say that it can cause inflammation as well. So, we'll ask people, if there's so many variables in the equation, if we can take a noise variable out, that's going to, make it a little bit easier for us to interpret, what's going on as you move through the protocols, see how it goes. And, many of these patients have already taken themselves off. They've already figured it out.
Right.
But it's not doing them any favors. And the same can be true for dairy and sugar and some other things.
So let's move on a little bit to the connections that are emerging between dental cavitations and MARCoNS. So for people that aren't familiar with MARCoNS, that's the staph that is commonly seen in the sinuses of a person with SIRS, multiple antibiotic-resistant coagulase-negative staph. And one of the things that I heard at the conference last year, and I think there's even more around this area now, is that in people that don't eliminate this sinus staph issue, it may be that they have the same organism in their dental cavitations potentially. And so I'm wondering if that is still something, a line of investigation that's being pursued, and how important is that in people that don't get rid of MARCoNS with the traditional bag spray, for example?
All right. So, you saw Dr. Ackerley, give a great presentation on patient with refractory MARCoNS who went to a biological dentist, holistic dentist, who did the cone beam CT scan, and they'll find cavitations in jawbone or in root canal zones. When they do, one of the approaches was, pull the root canal tooth, or do oral surgery, to get to a jawbone cavitation and treat it with ozone through a wand. Pull the tooth, treat the socket with ozone, and sterilize it. The patient got better. Patient got better, was able to, be negative on deep nasal cultures. So refractory MARCoNS is seeming to be more common. It's getting hard to get rid of it. And in the beginning, beg spray was working for MARCoNS maybe 70-80% of the time. We think it's decreased from that. We learned from Dr. Shoemaker and Dr. Musto, who runs the microbiology DX lab, that they saw a trend toward increased resistance to gentamicin and vancomycin. Now, those two antibiotics are potentially life-saving antibiotics, meaning if you find a bug that's resistant to everything else, those are two that we can turn to. If we're creating resistance to those, we're taking away, a potential life-saving opportunity. We want to be good antibiotic stewards. And so what was most interesting is that they correlated the gentamicin, vancomycin resistance with use of antifungals. And small numbers, that we can't say that we've proven anything at this point. But it forces us to think, are there things that we can do without the antibiotics that might work? And so both Dr. Ackerley, Dr. Rappaport, Sonia Rappaport have been using EDTA followed by colloidal silver, maybe some Coptis or olive leaf extract. I've used that. And we are seeing that, it does seem to work somewhat better. And we just learned from Dennis Hopkinton and Dr. Musto's lab and Ritchie that the combination of EDTA and colloidal silver seems to work better than the beg spray has been working.
Yeah, and I saw that Hopkinton now has that available as a compounded medication that people can get by prescription, and so that will be interesting to see how that plays out. Because my observation over the years, especially the last couple of years, has been people do the beg spray, and maybe they get an initial culture where it doesn't find anything, but then if they several months later culture again, it seems like it often is back again. It doesn't seem like it really cleared it for any long period of time.
Well, yeah, and so, is it the same pattern of resistances? Is it the same strain? Is it something new? How can we tell if they're, trading resistance genes like Pokemon cards, for powers against the host? The patterns could be changing for that reason. We don't really know.
Mm-hmm.
It's the thing that it used to be, only there's more now, or it's something completely different. The nice thing about colloidal silver is that you're not creating antibiotic resistance with it. The antibiotics, the genes for the resistance have to do with efflux pumps, so that when an antibiotic makes it into a cell, if you've got the gene for that antibiotic, you're kicking it right back out.
So what has your observation been clinically in terms of symptom improvement correlated to the eradication of MARCoNS? Is that a significant piece of getting a person with SIRS better?
Well, it can be, but sometimes we'll get rid of the MARCoNS and we're not seeing much in the way of symptomatic improvement from having done so. And it could be because there's just ongoing neuroinflammation from other sources that's affecting cognition or causing headaches and what have you. If we do see something and those symptoms persist, at least we may have cut back on the postnasal drip and congestion, and they're feeling better from that standpoint. There's also the reigning controversy about whether fungal strains can actually colonize we call it the rhinobiome. I think we're talking about rhinoceros or something, but the nasal biome. There's not a lot of research on it so far.
And it's funny that you bring that up, because that was going to be my next question, was this idea of, if we get exposed to all these molds environmentally and we're breeding them in, is it possible that there's some colonization of these fungal organisms within us as well? What are your thoughts?
Well, we've seen, one side argues that there's not enough activity of water, it's a technical term, to keep molds and fungal strains alive in the rhino biome. But, they can hide out in biofilm and stay viable that way. We find cultures that come back positive, were they just passers-by that we picked up when we did the swab, or, are they actually inhabiting the space? I don't know the honest answer to that, but, it forces me to keep the door open.
Well, and the good news is colloidal silver, as I understand it, is also antifungal. So if one finds that was a reasonable idea, that there was some fungal overgrowth, it seems that this solution with the colloidal silver and the EDTA would potentially address that as well.
Now, before we leave the subject, I want to add a little more news. In talking with Dr. Ackerley recently, I learned that when she sends somebody to a biological dentist now, this dentist is not pulling a root canal, is not doing, or referring for, surgery to do the dental cavitations, but instead, this dentist is injecting ozone, which is unpleasant. I would say more unpleasant than the actual deep nasal culture itself, where the anticipation seems to be worse than the discomfort in most cases. But at least it's not surgery, and you might be able to save a tooth, if you can sterilize a root canal zone with the injection of ozone. So we'll see how this plays out. But, it's still not ideal, but, I felt pretty awkward about, should I, advise a patient to have a tooth pulled and have oral surgery for this?
Yeah.
Is the data really substantiating putting people through this and with a high expectation of the benefit?
Well, and I have personally been through it. And while I think it was helpful, the question always is, did that permanently solve the problem, or does it come back over a period of time as well? I mean, I think it's unreasonable to think that the dental cavitation procedure is able to get every microbe out of there. And so, what percentage of the time do they become an issue years later? I don't know.
Yeah, that's right. And you can see people are starting to think already about, what's going to be the Xifaxan, the SIBO drug for the nasal space. And, it takes me back to the days when doctors would see this big shadow on an infant's chest and think, what's that? We got to take it out. They took out the thymus. The thymus is college for your lymphocytes. And so, we have to pull ourselves back. We've got a reputation for causing more problems than we solve.
I'm predicting that in the next few years, we're going to see many nasal probiotics that become available as well in nasal sprays. I know of practitioners that are using Megaspore with a very specific process as a nasal spray as well. I don't know why there aren't probiotics already in nasal sprays, but it seems like that will be an interesting area over the next couple of years, I would suspect.
Yeah, I think that would dovetail nicely with EDTA to disrupt biofilm and colloidal silver, that sort of thing. So we can be good antibiotic stewards, reduce antibiotic resistance, and rely on ways of tweaking what's going on in that microbiome, so that we let the competing bacteria do the work for us.
So one of the questions that someone sent me in anticipation of our conversation was, when you have someone that comes in and they've got mold issues and they've got Lyme and they maybe have parasites and viruses and fungal issues, how do you prioritize where to start? Do you always start with the mold, or is there some other way that you approach that question?
Well, once I added SIRS to Lyme cases in my practice, I came up against that immediately. I kind of assumed that be best to get the innate immune response out of this hyperreactive loop if you want to get more mileage from antibiotics against Lyme. The antibiotics are showing your immune system where the action is. They're not carrying the day. You need your immune system to carry the day. If it's not in a position to do that. So I reasoned, all right, let's go after the SIRS first. And I learned within a few months that, so many patients would be stuck at step one that we're just killing time. Time is flying by, and we can't even greenlight the treatment for the SIRS. So let's go after, the Lyme. And, I found that, if the natural killer cells and killer T cells are showing up in force and the IgG levels are okay, these patients would do okay. They would herx on tinidazole, and that would be our sign to continue to see, what happens to symptoms if we continue with something like Ceftin daily and tinidazole twice a week, possibly even doing pulsing of 2 days in a row, 2 weeks off, 3 days in a row, 3 weeks off. And they would make progress. And when the time came to greenlight the treatment, we could do both on parallel tracks. The challenge being, being able to time your binder around meds and supplements and meals. So, I think I assumed and I was wrong. So I will say this, though, that when you've got somebody who's got significant GI disturbances, whether it's bloating, cramping, distension, constipation, diarrhea, it may be that some of them will get better just on a binder, but I've learned over time that many of them, we need to focus on the gut first, and see, invest a few weeks in trying to set the table for better toleration of what's to come. Many of these patients also have signs of mast cell activation. So, the three most common physical signs that would tell us that there's a mast cell activation syndrome are hives, and a second would be what we call flushing, which is redness, upper chest, neck, face, maybe the ears, that feels hot, but it's not itching and it's not raised, it's not hives. So hives, flushing, and dermatographia. So on the thin skin of the forearm, on the palm side of the forearm, if you take a tongue blade or a pen or even your finger and just put your initials there and give it a minute or two, don't lose track of time because it might come and go, but you might see your initials in bright red. Sometimes it's even in hives, but if you got stuff like that going on, it says the mast cells in the skin are involved. That increases the risk that there are mast cells, elsewhere in the system, including the gut, that might be involved. And we'll start with ranitidine, which is the generic for Zantac. It binds the histamine 2 receptors, which are the receptors in the bowel. And that's often somewhat helpful. There's Neuroprotect, luteolin, and a couple of other.
I think quercetin and rutin, and that's the one from Dr. Theo Herodes, right? The Neuroprotect.
Yeah, exactly. And there's a lot of trial and error. I think even the destination centers for mast cell evaluations at major medical centers will tell you that unless you have mastocytosis or what we call a monoclonal mast cell activation syndrome, the serum tryptase, the beta tryptase, the 24-hour urine test are not likely to be positive. when they come back negative, we haven't ruled out a mast cell activation syndrome. What it often boils down to is trial and error on what you're eating and what you're exposed to, via the airways or the skin, and, kind of sorting out how to settle things down. And some people, it takes a really long time. They're super sensitive. Other people, they can get it under reasonable control if they limit these foods and cling more to these foods. It makes a difference. And, there's reason to believe that there's some overlap between SIRS and mast cell activation. MSH participates in the retirement of aged mast cells and perhaps the forced retirement of misbehaving mast cells.
Yeah, that's interesting. And part of the challenge too is in mast cell activation, as I understand, there can be so many different triggers, right? Mold could trigger it, parasites can trigger it, the foods can trigger it. And so probably in most of the people that you're working with, they have several things triggering the activation of the mast cells, I would guess.
When the mast cells get sensitized enough, they start reacting to benign things as if they're noxious. And that's when you're really in a deep hole with it, because you're doing all the right things and you're still highly reactive, and you add that to the SIRS inflammation and the dehydration with the low vasopressin levels. You're starting to really tax the autonomic nervous system and its ability to compensate for dehydration and poor autonomic regulation of the autonomics in the microcirculation. It becomes a real challenge, but what I tell patients is if we can get enough obstacles out of the way, don't underestimate what the healing intelligence of the system can do. We just got to get it some traction.
Yeah.
And that's often the case.
I had talked to someone recently who was dealing with mast cell activation. They were down to, maybe 5 foods, and they introduced ketotifen and DAO, and it was life-changing. I mean, their number of food choices opened up. They gained a healthy 20 pounds of weight. They just weren't as, weakly anymore. They had a lot more kind of stability and were able to do a lot more things that they hadn't done for many, many years. So it's pretty amazing how much this mast cell piece has come into play. And really only in the last couple of years that you hear people talking about it a lot. And now it seems like everyone is kind of being led a little bit towards the mast cell issue.
Well, this mast cell activation falls under environmentally acquired forms of inflammation and illness. And so we need to be looking at these issues. If there are other things that we should be paying attention to in indoor environments to reduce risks from something like that, we should know about it. But, there's just not enough attention being paid to what's happening in indoor and outdoor environments, how they're adversely affecting the health of so many people.
One of the questions that someone had sent was they're interested in the connection between SIRS and Ehlers-Danlos syndrome, and also between SIRS and POTS. So do you see connections between SIRS and those other 2 conditions?
Oh, it stands out. It stands out very strongly. I realized in, similar experiences with colleagues in SIRS that the looser the connective tissue, it seems the stronger the symptom intensification on binders. When you start mobilizing, toxins and inflammagens from tissue, if the connective tissue is loose, it's not sequestering the toxins and inflammagens as tightly, and so you get much more mobilization. And these patients, would say, I can't handle a 1/16 of a teaspoon of cholestyramine without reacting. And so, and there are so many other, associations here again. If you've got EDS and there's, venous pooling happening because the connective tissue is looser, the veins have collagen and a layer of their walls, and the heart is beating faster to try and compensate to get that stuff up through the pooling zone and through the lungs again. So there's a lot of POTS that we see. Some of it is dysautonomia related. Some of it is, maybe primarily dehydration that's hard to overcome. But, the best solution for these folks is if they've got Lyme, whatever we can do to put it into remission. And if they've got CIRS, whatever we can do to, reduce your carriage of these toxins and inflammagens and get into a healthy indoor space.
Yeah, and your comment about the Lyme and specifically around POTS is interesting too, because my understanding is there's also a correlation between POTS and Bartonella, and that oftentimes when people treat the Bartonella, that will help with the POTS as well.
Yeah, I mean, Bartonella is an endovascular infection. They hang out in endothelial cells, and those line the veins. And if those veins, if those endothelial cells are not responding properly to autonomic inputs, you've got a dysautonomia of sorts. And if you've got stretchy connective tissue, it's even more complicated. But again, we'll just keep emphasizing to patients who are unfortunate enough to have so many of these things going on at the same time that at least we're aware of it, and we know how to navigate it in ways. And we know that we tell a patient who's got the 11.352b genotype and the hyperflexibility and so forth that they have to go with lower doses, of a binder, because if you mobilize too much, it's going to be hard to function. And they go, so this is going to take longer. And technically the answer is no, because you're mobilizing more at a lower dose than somebody might at a full packet or scoop of cholestyramine. And so the challenge for any of these patients on CIRS is to try to find the highest dose strength and frequency that the body says okay to. And okay means, you've got some symptom intensification, but you can soldier through it and still function.
So you mentioned the 11.352b. I think people that are familiar with CIRS know that there is a genetic predisposition. There's these HLA-DR types that make you more predisposed to water-damaged building toxicity. That gene is something that we're going to carry with us for the rest of our life, as I understand it. However, in conversations with Dr. Shoemaker, he had suggested that the VIP at the end of the process potentially can kind of reset that gene expression such that you don't have to have ongoing binders for the rest of your life and be overly concerned about going to a movie and things like that. How do we really minimize the HLA-DR issues once we've largely recovered from CIRS?
Well, even with VIP, most people are still going to be able to detect when they're exposed. VIP doesn't make that go away. Whether VIP can change the underlying susceptibility, whatever it is, having to do with antigen processing or presentation or translation into antibody production. We'd love to interest some top-notch cell biologists to help us figure that one out. But there's another point to be made here too. Again, in conversations with colleagues who know patients who are 2 copies of the 4.353, so the so-called dreaded one, and exposed to indoor molds and bacteria and the inflammagens and contaminants and so forth. Somewhat inflamed, but able to function at high levels. So, how does that happen? One of the things that we can refer to is epigenetic differences between patients with CIRS. Some people have, epigenetic patterns that were based on, junk food and lack of exercise and, maybe gauntlets of stress and so forth. And they're losing, that added layer of regulatory ability, to at least keep yourself in the game. And so there's a lot to learn on that. And, it's a difficult area to study, but we have to account for these outliers somehow.
Yeah, and I think that makes a lot of sense. So I'm a 4.353 and I'm doing really, really well, but I'm also very particular about exposures and high density nutrition and all of those other things. So maybe that's the thing that kind of, keeps you going. MSH, obviously, we've talked a little bit about that. We know that MSH levels, generally speaking, the higher they are, the better people also seem to do. I know there's not a whole lot we can do in the US at present to raise MSH, but I'm wondering, are there some things that might help here? And then what's the role of HCG relative to increasing MSH?
Well, I don't know what HCG can do to increase MSH. It's something worth looking into, but one of our colleagues has done a series of HCG treatment in 5 patients with CIRS. And in each of those patients, or maybe if I'm remembering, maybe 4 of the 5, the C4A went from, upper teens, 20,000 range to, normal. And it begs explanation, like how did that take place? What mechanism did that? One of the patients was incidentally exposed, and so the others had CIRS but were free from exposure. That patient on HCG, the C4A did not go down. So it was serendipitous, and it makes us think that, well, there's a regulatory neuropeptide hormone that might have a role.
Interesting. Yeah, that's very interesting. Let's talk just a little bit about binders. So we know cholestyramine and Welchol generally used as part of the Shoemaker protocol. I've seen other practitioners that use bentonites and charcoals and zeolites and chlorellas and whatnot. Do you find that your patients benefit from the addition of any of those other binders beyond cholestyramine and Welchol?
Well, I go to Google and see if I can find out what ionic charge data I can find on a potential, alternative binder. Activated charcoal, has positively and negatively charged binding groups. Can bind heavy metals. I'm not in favor of working on heavy metals at the same time we're trying to mobilize other toxins, and I would leave that for later. Because the heavy metals can disrupt a lot of pathways too. And, cholestyramine and Welchol are 100% positively charged binding groups. They go by the name of quaternary ammonium. That's what makes them stronger than, charcoal and bentonite and so forth. Bentonite charge data is available online. It's 80% negatively charged and 20% positively charged, which actually might be beneficial for super sensitive people. To use that as opposed to something like cholestyramine. But you have to be careful with bentonite as well, because if you raise the dose too quickly, the clay expands in the gut space to the point where you could even, get impacted. So milder binding strength doesn't mean that there's nothing to look out for there. I've looked for charge data on chlorella. I think, unless somebody's done it in a lab, we're not gonna find it by the manufacturers of it. So I've been reluctant to use it, but I run into patients who've used it and felt benefits from it.
Yeah. My observation has been that if people are still getting exposed to mold or recently left a moldy environment, the cholestyramine often seems to just be the best. But at some point, it seems like they can, for more maintenance type things, potential exposures, but not, they're still living in it kind of thing, then the other binders often seem to be good maintenance tools or good tools combined with cholestyramine potentially.
And you can say, where's the data on any of these others? And there's none. But when the patient can't tolerate or afford cholestyramine or Welchol, and there's a lot of price gouging going on with Welchol, we have to do something different.
Yeah.
And so forced into using things like charcoal and zeolite and so forth, and we find patients progressing.
So as we start wrapping up here, this has been a great conversation, but I know that there's some things that you wanted to share around awareness and activism. So I'm interested in what is the role that patients and doctors really should play as activists in the SIRS and environmental illness arena? And then how much input do you, as a medical expert in this environmental illness realm, have into legislation things that happen around toxic substances?
Well, to start with SIRS, it's becoming increasingly clear that this is a major public health threat, and it's affecting way more people than there are experts to help them with it. And it's affecting them in ways that go beyond a lot of other chronic medical conditions, forcing you to move and incur, all kinds of expenses, having to quit a job or miss a year of school, and the patients are sick and tired of being told there's nothing wrong. Many of them are treated brutally. I'd say for the most part they're given excellent care by primary care and specialists, but they just don't know what they're looking at, and so they spend a lot of money and don't get anywhere. Mayo has a pretty poor track record of helping any of the SIRS patients that I've run into. So we're looking for ways to help raise awareness, and 4 of us, that would be Scott McMahon and Mary Ackerley, Sonia Rappaport, and myself, have founded a 501c3. It's a new professional society, that we founded to help educate colleagues, the public, give patients new ways to advocate for better care in this area. And it goes by the acronym ISEAI. We call it ICI. That's International Society for International Society of Environmentally Acquired Illness or Inflammation. We'll decide what the second I needs to be over time.
Nice.
And so, we're very excited about that. Ritchie can't do it all by himself. He needs help. He should be proud that some of his stepchildren have, branched out and are trying to build upon what he's established. So, it's environmentally. It's not just indoor environments. In the outdoor environments, glyphosate and persistent organic pollutants of so many kinds, disrupting hormonal pathways and detox pathways and causing neurological effects. In 1976, they passed the Toxic Substances and Chemical Act. And, it was hailed at the time, and, a lot of environmental awareness at the time, but it was a pretty toothless piece of legislation. And so 40 years later, they got interested in updating it. So in June of 2016, the updated TSCA, the Toxic Substances and Chemical Act, was passed, and everybody was patting themselves on the back for the bipartisan effort. It was bipartisan politically, but the stakeholders involved in this involved chemical companies, their political patrons in Congress, and some token representation by environmental groups, like the Sierra Club. And the environmental groups were not really happy with it because it wasn't doing enough. Sadly, missing from the table were physicians and scientific experts on the adverse health effects of these untested. In 1976, one of the gripes against the first version of the act was that 60,000 chemicals that had already been in use were grandfathered in and didn't have to be subject to any testing. And what actually helped prompt the update of the act was chemical companies worried that states were starting to take action on their own. Like Washington State was regulating flame retardants, for example. Well, if they're going to do that, where's it going to stop? So the House version of the update of the act was going to take that away, take away the state's federalist powers when it comes to regulating, toxic chemicals and substances. And the pre-market testing that's, supposed to be the EPA's responsibility, there's no funding for that. And, it's a bit of a joke. So, this is the century of biology. If we don't learn the rules of biology, we're not going to fare very well. And so, we have to raise our voices, take a stand, be more politically active. But it's also, about education and, interpreting the science correctly and calling for better science when we need it. Because, we're thinking about our kids and our grandkids and, a few generations ahead. How many warning signs do we need? So it's time to pull together, as professionals, as patients, other members of the public, and hopefully, we'll start electing people who, like Jimmy Stewart in that movie would, filibuster until he could barely stand up for a good cause. And, try to reward the companies that accommodate, our concerns about the quality of, what's in our food and, what's being dumped into our rivers and streams, it goes on and on. So we don't want to draw any sharp boundaries here because it's a big issue.
Yeah, absolutely. And I think that those, environmental factors, the chemicals, pesticides, metals, toxins, food quality, all of that, I think they're probably the largest contributor that we have to the health of America today. It's really shocking.
You see doctors in the trenches mopping up after the effects of this day in and day out, long hours, and we don't even get a seat at the table at the update of the act. So that has to change.
Well, I'm excited about learning more about this new nonprofit organization that you all are putting together. Let's wrap up with one last question, which are, what are some of the things that you do on a daily basis to support your own health?
Well, my second daughter got me into a calisthenic routine. This came from the Fire Engine 2 guy. And very simple, but, I spend, maybe 10 minutes doing that each morning, and it gets the blood flowing and, you feel ready to take on the day. That's nice. And my two daughters together have become vegan, and they've, kind of won me over, not to crossing all the way over to veganism, but to go plant-based as often as I can. And I actually feel better that way. So there's that. And probably the biggest thing that I've done for my health is find a way out of 10 years of practice as a solo physician administering a practice that refused to quit growing because I didn't know how to say no to new patients who needed help. And, it became like the tennis ball machine gone awry.
Yeah.
I have to add here that for many of my patients, my intent to move to Chapel Hill, North Carolina from the Chicago area was not happy news. But I have been so blessed and graced by kind words of encouragement from my patients over the years to take care of myself and keep at it. And, once you start feeling better, model how to stay that way.
Fantastic. And I know you're in a great place now with Dr. Sonia Rappaport as well, who is another hero, I think, in this realm of SIRS and mold and Lyme and these complex chronic conditions. And so I want to thank you for spending time talking to us today. We covered a ton of great information. I mean, I was having a great time. I have so much respect for the work that you do. It's nice for those of us who have been through or are going through illnesses like SIRS and mold and Lyme to know that there's people like you out there that care enough to learn about how to help work with patients and how to help people recover their health. So you are a hero in my book, and I appreciate you being here very, very much.
Well, right back at you. You're one of the best chroniclers of what's worth knowing in the growing field of complex forms of chronic illness. So hats off to you.
Thank you very much. To learn more about today's guest, visit havenmedical.com. That's havenmedical.com. I appreciate your support of the Better Health Guy blogcasts series. If you'd like to follow me, you can find me on Facebook and Twitter as Better Health Guy. The show can be found on YouTube, iTunes, Google Play, and Stitcher. If you'd like to support the show, please visit betterhealthguy.com/donate. And if you'd like to be added to my newsletter, please visit betterhealthguy.com/newsletters. I'm looking forward to many more shows ahead and appreciate your interest.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.